So thanks so much for joining me today. I am Christina Bauer with the Texas Lyme Alliance, and I have Dr. Robert Bransfield, who's the leading psychiatrist recognized in the Lyme community as being at the forefront of treating patients with neuropsychiatric symptoms of tick-borne illness. And he has over 60 patients on Disulfiram, and so I wanted to reach out today and get his opinion on Disulfiram and how he's doing in treating Lyme patients that end up with depression. As everyone well knows, May is Lyme Disease Awareness Month, and one of the biggest things that I wanted to discuss today was how to prevent suicide and depression when treating Lyme disease. So thanks for joining me, Dr. Bransfield.
Thank you, Christina. Happy to be here.
Good, good. As I know you are super busy, I wanted to absolutely thank you for all of the work that you do for Lyme patients. Start off with that and let you know that the work that you do helps save lives. It's very simple. And I wanted to get some information out today to the Lyme disease community from you and how to avoid depression. How many patients do you have? I said about 60, but is that accurate on Disulfiram right now?
That's about right for Disulfiram, yes, although I have a much greater number of Lyme patients I've treated or currently treating.
And are most all of those chronic patients that you've prescribed Disulfiram for?
Yes, yes. None are acute, they're all chronic.
Right, that's typical. And how's it going? I know that's a general statement, but I like to give Lyme patients a little bit of hope. You wouldn't have put, that many on if you're not seeing good results.
Well, my first patient was a lady in Europe, actually, and that was maybe close to 2 years now.
Oh,
and
wow.
She had terrible intrusive symptoms. She was in a wheelchair. She came to my office in a wheelchair.
Okay.
And she had hallucinations, suicidal, a lot of pain. And she's been on it. She does get a herxheimer reaction, but now, and she's actually still on quite a low dose, but the intrusive symptoms ended, and they can be horrible.
Yeah.
And she's no longer having hallucinations, and instead of being in a wheelchair, she's very happy. She can run up and down the steps, and she can work in a garden, and she can play her violin.
Oh, that's
so
fantastic.
It's been a major improvement for her. And that was my first patient, and I've had many others since. And one had neuropathy after being on a significant dose for a while, and we backed off. And some are hard to get started.
Yeah.
I think you have to be careful not to be aggressive and start too high a dose too fast. And normally, I think the average person, we're starting at a quarter of a tablet every third day.
And
so
that
that's
would
62 milligrams every third day. And then we gradually increase. But some people are very drug sensitive, and those people that need a lower dose, it's hard to cut it smaller than that, so then we get it compounded.
Yeah.
We go to compounding formula pharmacies, and I've been as low as 5 milligrams with some people.
Wow.
Other people 25 milligrams, but some people are very, very drug sensitive and get a significant herxheimer reaction.
And when you say 5 or 25, not to interrupt, but is that a week or every 3 days?
Well, we give 5 milligrams. We start maybe every 3 days, and then we go to every 2 days, and gradually work our way up slowly. A problem is that the organism reproduces on a cycle.
Yeah.
So you can think that a person has a tolerance, and then you increase a week or two, and then you suddenly hit that reproductive cycle. And when you hit that reproductive cycle, then the person gets the bad herxheimer reaction. Now, when that happens, then I tell people, don't take the next dose until you've improved from that.
Good, good. Yeah,
and
that's
don't
what
be
we're seeing.
rigidly stuck with that dose.
And then are you incrementally going up but not increasing within a 2-week time period? That's what we've learned.
Right. I go up slower than 2 weeks.
Oh, good.
So I give it more time. There's no rush. Now, some people are also on antibiotics at the same time, so I'll add it to whatever they're on. And it's been a slow process. The difficult thing is, what's the end point? When do you stop giving it?
Right.
And it's, I've seen the thing that usually improves first is fatigue. And that's usually what gives the herxheimer first, is the fatigue. And then and when fatigue improves, that permeates a person's entire life.
Yes.
And when you have had fatigue for so long that you forget what it's like to not have fatigue, then you see this improvement, and that's a major, major advance. That's usually the number one symptom with persistent Lyme disease is fatigue.
Yeah.
And that's the most disabling, and it's incredible how many different parts of other functioning it impacts, be it mental fatigue or physical fatigue. And one of the last things I think to improve are some of the neuropsych symptoms. Those are the hardest to treat, and that takes the greatest amount of treatment. Usually the aches and pains sometimes treated first, and a lot of times the people that do well with this are the people that respond to antibiotics but relapse as soon as they go off.
And how long have you been treating Lyme disease? That's most people know you and know you've been doing this a long time, but for anybody who doesn't know, how long have you been treating?
Well, probably without my knowledge, 50 years, okay? But with my knowledge, 30 years, I'm in New Jersey, and it's a very Lyme epidemic area.
Yeah.
And I specialized in a lot of treatment-resistant patients, and many of those ended up being Lyme patients. It just kept coming up again and again. And the first people that I saw were people that were declared cured because they had a month of antibiotic treatment, and that should have been enough. And they weren't cured, and then I would give them more, and they would get better. But then I see other people that have been maybe on years of antibiotics and are not improving, and those people I would treat more with the psych med. So the basic logic is you want to, I do an assessment and I figure out what's the worst symptom, how do your symptoms fit together?
Yeah.
And with some people that have never had antibiotic treatment, that's a good option. But with people that have had a lot of antibiotic treatment and not enough symptomatic treatment, then you do symptomatic treatment. So you look at the symptoms that keep people stuck the most. Mm-hmm. You're also looking at what would make the immune system stronger. And so you're trying to improve the immune system, but chronic stress, sleep deprivation are often quite catastrophic in making someone more immunocompromised. So in treatment for symptoms, a lot of times the first thing I work at is improving quality of sleep, deep restorative sleep. If we get that, then that helps for immunocompetence.
And how are you doing that? Like an Ambien or something like that?
No, well, Ambien, your FDA-approved treatments for sleep only help onset, and they do not promote quality of sleep. What you particularly want is the delta sleep. So Ambien has longer sleep duration, but not improved sleep architecture.
What are you seeing helping Lyme patients as far as sleep?
Well, trazodone is often what we might start with.
Okay.
Because if you look at sleep aids, one problem is they can cause dependence and tolerance, and another problem is that some can cause weight gain.
Yeah.
Trazodone, and everything has a side effect, but trazodone can be a good starting point because it doesn't give the weight gain, and it doesn't give the dependence and tolerance, and it promotes the delta sleep. So,
okay.
And then we go through the list, and a lot is individualizing it depending on the person. And we often refer to as the terrible triad as non-restorative sleep, cognitive impairments, and fatigue. So that if you can improve the quality of sleep, then you improve cognition and the fatigue. And once you help with those three things, that makes a big difference.
I do want to interject here that we're not recommending any drugs today. We're not recommending Disulfiram or any of the drugs that you're talking about. This is for educational and discussion purposes for people that are interested in using Disulfiram to help with Lyme disease, but we're definitely not recommending any drugs to people today. So that's for me. You're allowed to do that.
Yeah, I agree, although everything is individualized. And
exactly.
I think what you have to realize is that there is no proof of what would work. We can do studies with 100 people, 1,000 people, 1 million people. We can do a study with your twin, but that doesn't mean it'll work for you. So you never know what's going to work until you try it on that person. Mm-hmm. And it always has to be individualized. You can never do something en masse that works for everybody.
So as you well know, I've already introduced May as Lyme Disease Awareness Month. And one of the things that I wanted to focus on this month is suicide prevention. Can you share with us some statistics as far as, I know they're poor, but could you share some statistics with our audience on the risk for suicide in treating Lyme disease?
Okay, it's come up a lot, and I've had a lot of people that were suicidal, and then you treat the Lyme and they're not. You also have to be careful that when you give a aggressive treatment, that may cause a herxheimer reaction, that may momentarily increase suicidal risk. That can be a part of it. But a very, very high proportion of Lyme patients, in one study it was like 28%, and another study it was greater, particularly late stage Lyme or persistent Lyme are suicidal to some degree or another. And that's a high risk. Now you can understand it with the physiology.
Yeah.
And a lot of times I'd go to a meeting with, let's say, other doctors treating Lyme, and I would say, what's the #1 cause of death in Lyme disease? And the #1 cause of death invariably would be suicide.
Yes, sir.
Now, if you think after that, there's also drug overdoses, that's probably #2.
Okay.
And then there's different neurological, or maybe Alzheimer's, that might be #2, or it could even be #1. It's hard to see that connection, particularly the slowly progressive Alzheimer rather than rapidly progressive. And other neurological impairments, cardiac deaths are a small percent, but that gets a lot of attention. So it's suicide without a doubt. And then whenever I would give a talk, and it might be to doctors or the public, and I would say, how many of you know someone with Lyme who's suicidal or who committed suicide? And a lot of hands would go up. It would be, with doctors, it would be probably 100% who actually know how to treat it. And with people that have experience with Lyme, probably 2/3 would raise their hand. So that's a straw poll, but that's not formalized. But when you look at the percent, there's a high percent of people with Lyme, with the late stages, who are suicidal. Now we see that with other infections. And there were studies in Denmark where they look at infections, and any infection of significance can increase the risk of suicide because of the way that it affects the brain. You get pro-inflammatory cytokines, it impacts quinolinic acid, and that's an NMDA receptor agonist that then increases the risk of suicidality. So it's any infection of any significance, particularly when it's persistent, when it's chronic, it increases the risk. And with Lyme, we see partly that physiology, but then there's a psychodynamic part. Okay. Because there's a social part too, where you get Lyme, and the average person that gets Lyme is normally a athletic, active, outdoors person. That's why they get it. Yeah. They don't usually get it sitting on the sofa watching TV, but that sometimes occurs. Yeah. And so then they're a very active mover and shaker, lover of life. Then they come down with Lyme, and now they have this chronic fatigue condition that's totally contrary to who they are, contrary to their personality, contrary to their self-image, and it's very frustrating.
Yes.
Then they find that the NIH, CDC says, well, this is a medically unexplained symptom. Families have trouble understanding it, and doctors have trouble understanding it. So, and their insurance company denies them. So they hit barriers everywhere, and they may have 100 different symptoms from Lyme. And some symptoms have a greater risk than others. I did an analysis in an article I did on Lyme and suicide, and I looked at which symptoms correlated the most with suicidality.
Which were those?
Well, particularly anhedonia, although I had a list here, and it was, for instance, I could read them off a little bit. Sure. Hallucinations, explosive anger, dissociative episodes, paranoia, disinhibition, intrusive symptoms, bipolar, mood swings, panic attacks, depersonalization, substance abuse, social anxiety, hypervigilance, general anxiety, anhedonia, chronic pain, depression, and cognitive symptoms. And anhedonia, I think, is particularly a big one because if
What
you
is
look,
that? I'm not familiar
okay,
with that term.
okay, hedon is a Greek god of pleasure.
Okay.
So hedonistic is pleasure seeking.
Yes.
If you think of the movie Animal House with Bellucci, maybe that's before your time.
No.
But,
Yeah.
but okay, all right, a lot of people have seen that movie. That is a good scene for hedonism, where he's drinking and partying and everything to excess. But people that are hedonistic are really anhedonic because it's difficult for that person to have pleasure. If you're hard of hearing, you have to turn up the music. So if you can't enjoy things, you may be more likely to do substance abuse or extreme risk behavior in order to feel.
Okay.
So if you think, why do we get up and go through our lives every day? We have certain pain and barriers and obstacles, but that's not so much the problem as if we get gratification, purpose, meaning, social connection, something that motivates us, inspires us, and makes us want to pursue and be motivated each day.
Yeah.
That's the big thing. And some people, that's a circuit of reward.
Yeah.
And if that isn't working, so we get no pleasure from a pleasurable activity, then that is a high risk for suicide. So if someone starts talking about Kierkegaard or listening to Marilyn Manson music, they relate to anhedonia. And they don't get the joy. And you usually don't get joy. You can have peak moments when you graduate, when your child's born, when you get married.
Yeah.
But it's more the everyday, minute-to-minute pleasure of life, and most of that is everyday social interaction. So, for instance, if you have social anxiety, if you're socially isolated, that's a problem. That interferes with our normal joy of living, and that pushes people more in that direction. So there's a lot of things. It's a very complicated formula of what makes you want to live and what makes you a person suicidal and what are the acute triggers of why someone might become suicidal. So some of those are totally physiological because some of those, it can come out of the blue and it makes no sense.
Yeah.
And that's more physiological rather than psychodynamic, but both are there. And in any given person, if you look at what makes them suicidal or not suicidal, it's a different formula with different people.
Okay, that's really interesting. And I don't want to discuss COVID just yet, but we mentioned earlier, you said that social isolation can be a problem with COVID patients and Lyme patients. And there's some of a cross between the two types of patients, but I would like to, if we have a little bit of time, to touch on that a little bit later on. But this is also interesting. Dealing with depression is such a big, I didn't identify as ever being a depressed person as a Lyme patient. I've had it I was 8 when I got it, and I'm 47 now. So I've had it a long time. It went undiagnosed for 32 years. So my issue was more anxiety and panic attacks, those types of things. But what can Lyme patients do to lessen their chances in getting depression from brain infections? Because when you're in it, it's hard to identify that this is depression, or we know anxiety very easily, but depression is sometimes kind of hard when you're in the thick of it to identify. So what can we do as Lyme patients to lessen our chances of getting depression that may lead to a risk in suicide?
Well, it can sneak up on you. So if you were that young when you acquired it, you may not know what it's like to not be depressed. It may be hard to know what it's like to not have fatigue or not be anxious.
Yeah.
There's a loss of reference point, or not to be brain fogged. And you might look at other people and you can see that somehow they operate differently. But it's hard for that reference point. Certainly different from COVID. It's like, okay, this hit me all of a sudden, and I can see I'm not the same I was last week.
Yeah.
But Lyme, by its very nature, sneaks up on people. And it sneaks up slowly, and it's sneaky over a period of weeks and months and years, and it gradually erodes at your functioning.
Yeah.
So, and because of that, people don't pay attention. We're often crisis oriented in our society. We respond when there's a crisis, and if it's not a crisis, we ignore it. So
Yeah.
Lyme just slowly creeps away at our productivity and our functioning. So it's not an acute crisis that draws a headline. It just quietly erodes. And now there's depression, and there's two major parts of depression. One major part is negatives are more negative. So negatives are more exaggerated. And then the other part, which I was referring to before, like anhedonia, is where positive capability is blunted. So there's an impairment in the joy of living. Now, both can be there, and some people have more of the negativity, which maybe goes more with anxiety, and some people have more of the lack of positive that goes more with apathy.
Okay.
And then the anxiety, you can see different anxiety subtypes. You can see a PTSD type of problem. You can see intrusive symptoms, social anxiety, panic attacks. When you see panic attacks with Lyme, it's quite diagnostic when panic attacks last more than a half hour.
Oh my
Most people that have run-of-the-mill panic disorder that not associated with Lyme, it only lasts a few minutes. It can seem like an eternity. But with Lyme, they can go on beyond a half hour. They can go on for hours or all day, and they can be called rolling panic attacks. Quite diagnostic of Lyme disease. I've only seen that with Lyme disease. And so that's like a red flag. And it's hard for someone to comprehend how horrible that is, you know, how distressing it is. And it's these things, you think of anxiety, fatigue, cognitive impairments, attention span problems. The average person can relate to it, or depression, but not to that magnitude. So everybody gets down a little bit. And think of depression as a normal adaptive response to futility. Mm-hmm. If I do something and it's not getting anywhere and I feel futile, it makes me withdraw, be introspective, regroup, and redirect energy elsewhere. That's a good thing. But when it's pathological depression, it's entrapping and it's paralyzing. And that's a very different thing that other people don't understand. It's not the same as feeling depressed that you have to go to work Monday morning. Right. It's a very different magnitude. Just like fatigue is not everyday exhaustion from activity. It's very, very different.
Yeah, it's debilitating when it's Lyme disease induced by Lyme disease.
So people don't understand, and a problem can be a lot of the medical community doesn't understand. A lot of your thought leaders in infectious disease were trained 40 years ago, and their psychiatric training then would be a 1-month rotation through a state hospital. And that might have been the last psychiatric training they had. So they can't connect the dots a lot of times where you see this infection, it has this immune effect, and it doesn't have to be in the body. In the brain, it can be in the body. That alters neural functioning, causes the anxiety and depression physiologically. But you have this combination, like with anxiety, there's stress and then stress reactivity. So with Lyme, you have more stress you're under. It's hard to function with these impairments, but then the reactivity to stress is injured. It's not normal like it used to be. So it's a 1-2 punch. And with anybody, it may be more one or the other or both. So again, it's how do these symptoms fit together? And they all fit together differently in different people. So there's a joke of a computer repairman. He comes in and he looks at the computer, says, fix it. So he kicks it in the left-hand corner and then it works. Says, that's $100. I said, well, you just kicked it. How can that be worth $100? I said, well, $5 of labor for kicking it, but $95 of knowing where to kick it. So when you have all these symptoms that all interplay and interconnect, where do you have to kick it? Where do you have to change things so that you can put your greatest effort where it's going to have the greatest effect? What's the linchpin in sorting through all these symptoms? Yeah. So often it's non-restorative sleep or whatever stress, symptom, be it panic attacks or depersonalization or depression, addressing that and then working your way down the list. And then a person's less stressed and their immune system works better.
Yeah, sorry for interrupting. And how do you address that with a Lyme disease patient that's having those symptoms of depression, anxiety, panic attacks? What's the typical? I know everybody's individualized, so it is hard to pinpoint one thing, but commonly, where would you start with a patient like that in psychiatric meds?
Well, then I would look at, okay, let's look at all your symptoms and let's look at what side effect you don't want and what side effect you could better tolerate. So for example, if someone has panic attack and irritable bowel and insomnia and depression and anxiety, I might think of something like and doxepin, because that calms irritable bowel and that could help anxiety, could help panic, could help depression. It's one of the older tricyclic antidepressants. It might give weight gain, but that's at a higher dose. So you're always looking at what side effects could you better tolerate, and what therapeutic effect do we want the most. And there's a saying of the young doctor gives 10 drugs to treat one condition. The older doctor gives 1 drug to treat 10 conditions. So that's what you're always trying to do, is trying to streamline it so you're not overloading. A lot of people with Lyme disease are pill weary. They may take 70 pills a day with different supplements, and you don't want to add another 20 pills. So it's what is the most efficient way of breaking the logjam of that vicious cycle, and knowing that what starts a disease process may be different than what perpetuates it.
That's excellent information. Okay. So would you recommend Lyme patients who are undergoing treatment to have a psychiatrist on hand to help with these types of maladies that go along with Lyme disease, treating Lyme disease? Or
I think it would be a good idea if, let's say, their main symptoms are psychiatric.
Okay.
Now I see particularly Lyme patients where their main symptoms are psychiatric. And I guess the rheumatologists see the patients where their main symptoms are the joints.
Right, pain, yeah.
So there's a tendency for patients that gravitate towards a specialist that's has their addresses their predominant symptom, whatever that may be. Now maybe they might see a rheumatologist and a psychiatrist, or an ophthalmologist or a gastroenterologist, depending on what their main symptoms are.
Right. It's always very piecemealed. As I discussed earlier, I've had this for so long, but GI was my first problem was starting at 13 with ulcers and progressed. But nonetheless, it seems that any of the Lyme patients that I talk to, they all have GI distress. So I think that's really important for psychiatrists that may be listening today to use that as part of the equation, that what you mentioned, GI is very typical along with some of the other symptoms that you mentioned.
GI or irritable bladder, sometimes that's the #1 symptom with some people, particularly when it then causes anorexia. Now, you're from Texas, and Dr. Harvey was from Texas, and he and I collaborated in the past, and he's since passed away, but he recognized how significant the problem was in Texas, and he found a lot of a high number of patients there in what was considered a non-endemic state. And so that's there's a lot more of it there, and then his hypothesis was that there was a congenital component to it that was significant.
All 4 kids got it from me. It's been, we're from Illinois. 2 kids were born in Illinois. That's where I grew up. And then that's where I got it. And then 2 kids were born here in Texas. So Lyme definitely is in both places because I brought it.
And I think there's a lot of it in the population, and
Absolutely.
I think it's hard to ever get rid of it. I think once it's in your system, and it isn't just Lyme, it's tick-borne disease.
Right.
And it's I've looked at a lot with autism. That's another area that I've looked at, autism and developmental disabilities, and I think that's a very big piece there. But the error that a lot of people do is they do the 2-tiered Western blot, and at that point, when you have congenital, you don't recognize it as foreign. You need to use PCR, or you can often see improvement from the antibiotic treatment. Yes. So you have to do the proper testing, and that's the error with a lot of the people that say, well, there is no such thing as congenital Lyme, but they use the wrong test.
That's right. And we did IGeneX So 3 kids were indeterminate, which clinically, given their history and my history, is a positive from an LLMD, a Lyme literate doctor, but 1 was positive, and they've never been bit by a tick. So it definitely, they started showing signs and symptoms early on. They've been treated 6 years. We're all doing great, thank God. But this is such a generational problem, or it can be a generational problem. People need to know what to look for, how to test. Do you recommend things like IGeneX or some of these like Galaxy for Bartonella? I know some of these tests are very good, but when you mention PCR, that's maybe not so accessible to everyone. Something like IGeneX I can order on.
That's very useful. And for instance, I did an article where I looked at 3 generations, and then after I did the article, there was a 4th generation with it.
Wow.
So we were tracing it through that family.
Yeah.
But you have to look at the full complement of the Western blot. So the cheap things that insurance companies work deals with, you know, those companies, they only show what are considered the CDC Dearborn bands, and I want to see all the bands.
Right.
I want to think if there's a specific band that's reacting, then that tells me something. How else would they have reactivity of that highly specific band?
Yes.
You just can't go by the CDC surveillance criteria, and the CDC recognizes that. If you look, there's 4 million Lyme tests done a year. Or no, 3.4 million, I think it is. Yeah. And out of that, there's like 30-some thousand positive tests. So you're really looking at 1% of the people that are tested. You know, 100 times someone thinks this person might have Lyme, only 1% gets diagnosed when you figure out the math. And the CDC recognizes that they're off by at least 10%.
Right.
So it's a far greater issue, and I would almost be better with no testing than with unreliable testing, because
it's a real
people
problem.
Use it for screening, and it's not a valid screening test.
That's right. I know Bay Area Lyme just did paid for a study that showed that 71% of the ELISA test, 2-tiered test, of a patient group that had the rash, the target rash, bullseye rash, were negative, that actually were positive. So it failed 71% of those patients.
And the vaccine trials showed that. The vaccine trials looked also at PCR culture and the bullseye rash. And a lot of those people tested negative, a significant number. So it showed how poor the 2-tier testing was. That was a disaster when they did that meeting in Dearborn, and we're still feeling the negative impact of that. And that's contributed to this chronic disease epidemic that doesn't have to be so chronic if it were managed more properly.
In the acute stages, yeah, and the cost, just to mention the cost to families and government and insurance companies, they're not looking at this right. I would really like for them to start flipping this upside down and say, okay, something like Disulfiram, for people with insurance, cost me $10 a month to do that treatment. It could save insurance companies and SSI, disability type of payments out from the government. It could really save everyone involved, especially the families who don't have the resource some others do to treat, because most every Lyme disease treatment is cash pay.
Well, let me address cost, but I'll address one thing about the Disulfiram.
Please.
There is 2 articles looking at Disulfiram that it acts as a protease inhibitor against SARS and MERS. Mm-hmm. So I've had people on Disulfiram, and their whole family or people around them are infected, and they do okay.
Infected with COVID?
With COVID,
yeah. And they're okay.
So, yeah, it has a preventative effect against COVID. You know, there are many of the Lyme treatments we use that are preventive against COVID. But the other thing with the cost is Most disability is at the tail end of someone's life. Emphysema, heart disease. But Lyme can cause disability beginning in childhood.
Early.
For decades. So when you look at the lost productivity, the years of disability, the caretaker burden, it's catastrophic. It's not like degenerative diseases where, okay, it's a few years. You're looking at how many years, not just of the cost of being the medical care, but the lost productivity. And now you have to add that to it. And the cost of the drugs is insignificant compared to that. And there aren't studies that fully look at all those facets to it. The suicides or the drug overdoses that you see and how that impacts other people around them. You have to look at all these indirect costs. It's catastrophically financially when you look at that. But there isn't that. I wrote an article about that in '98, and it was a response to a cost of Lyme disease that was published in JAMA. And you have to look at these other direct costs, but still there isn't enough focus on that.
No, there's definitely not. And I was diagnosed with medical PTSD, which I didn't even know existed. But it's because of the decades of denial and not being treated appropriately. And I believe I've passed that down to some of my kids because they had seen a lot of trauma that they didn't need to see. This could have been addressed. And like you said, I was very athletic and outdoorsy and so forth, but the cost isn't the impact of what this has cost taking moms out of the kitchen. A lot of times I hadn't been able to tuck my kids in when they were little because I was in bed and couldn't move, debilitated from Lyme and so forth. So the cost to a family is way higher than the financial burden, which has leveled a lot of people. So
there can be a multi-generational cost, but another part can be that Lyme can cause intrusive symptoms, and intrusive symptoms are a key thing with post-traumatic stress. So you have more trauma, and not everybody has trauma as post-traumatic stress, but intrusiveness is a big part, and the intrusiveness then leads to avoidance, hyperarousal, and emotional numbing. And that's a physiological symptom that can be treated with that patient I was talking about had severe intrusiveness, and in her case, the Disulfiram works. Sometimes we give meds that reduce intrusiveness. And in some people, that's the #1 symptom is the intrusiveness and correlates with the post-traumatic stress.
And do you mean intrusiveness of the disease on a family or thoughts?
No, intrusive thoughts, intrusive images, intrusive emotions.
That's what I thought you meant, but I wanted
something comes to your head that is not something you would voluntarily generate that's supportive of your self-image. So it would be get a gun and shoot everybody. It's like, where did that thought come from? Why is that coming in my head? People would say they would have an intrusive thought that they want to kill every living thing in the house. And then they get upset that, my goodness, what's wrong with me that I have this thought? Sometimes that makes people suicidal because they're scared by themselves. They feel maybe they have to kill themselves so they don't harm anyone else. But some of these, like family suicides, where they kill the family dog, they kill everyone and themselves, and it's like, what was that about? Where did that come from? A lot of times you do see that, and I work with people who struggle with that. I did an article where I analyzed 50 people with Lyme who were homicidal.
I
looked at the statistics there, and it was rather scary. Now, most people that get Lyme do not get homicidal,
right.
Or a few people may have these intrusive thoughts. And whenever I give a Lyme talk to, let's say, the public, and I talk about intrusive symptoms, I can see people nodding their head because it's not something someone wants to volunteer. Some people describe it like clips from a horror movie. It's if you watch a cheap horror movie and you shift from one station to the next, that's what the intrusiveness might be like. It's like those images, horrific intrusive images. Now that can cause nightmares and sleep disorder, but you can get daymares where it comes through in the day.
Yeah, that's really important. I actually want to stay focused on this for another minute or so. I just got indicated, by the way, that we have as much time as as we need to
Okay.
stay discussing this topic. So I reached out to a Lyme literate pharmacist that I work with around the Disulfiram movement and within Texas Lyme Alliance. She's part of our scientific board, and asked her if she had questions or comments that she had for you. And this is super important, I think, with Disulfiram patients that are using Disulfiram to treat Lyme disease. We're seeing where we typically tell people, okay, it's great to titrate up to reach a maintenance dose on Disulfiram, but a lot of times what happens is because it's such a broad spectrum treatment, sometimes the herxing becomes too much or the cytokine storm becomes too much where people have to cold turkey cut it off, which can be dangerous. We're seeing where if people titrate down, they have less of a dopamine crash. That's my layman's term. Where, you know, depression is pretty immediate. What can patients do? Titrate? Do you recommend people titrate down once they reach the maintenance dose for, you know, 60 to 90 days, as Dr. Liegner pointed out, and then titrate down once they reach their desired?
I would certainly take longer than 60 to 90 days, and I would certainly titrate up very slowly and titrate down slowly.
Okay.
And I think what happens a lot of times is someone gets a bad herxheimer reaction, or they may get something that may in fact be a side effect, or they think it may be a side effect, and then they suddenly stop it.
Yeah.
Now, it does have a fairly long half-life, because if you were giving it for alcoholism, you'd have to wait 2 weeks before someone could be exposed to alcohol. But it does work on dopamine hydroxylase, so it blocks that enzyme. So when some people take it, they get a mood-lifting effect. So it increases dopamine, and dopamine goes with what I was talking about before, with anhedonia. So it helps reduce the anhedonia. It helps with the pleasure of life. And so then if you suddenly stop it, you may get a rebound where a person could be more anhedonic. Now, therefore, we'd have to think, well, what would help the dopamine? Now, when we have a problem with dopamine, we normally think of meds that may help that way. Bupropion is one that we think of first.
Okay.
Since that works somewhat more with the dopamine system. But many of our antidepressants instead work through serotonin. And if you give too much of a serotonin type drug, it may worsen the anhedonia, because there can be a numbing effect. A person can be just numb to reactivity, and it's somewhat anti-dopamine. So that's something to be careful of. And I think if someone's on a significant dose of an SSRI antidepressant and they abruptly stop it, they might have more trouble than if, let's say, they're on a dose of let's say, bupropion, and then they stop it. It may be a more gentle drop-off, but they're probably better stopping it more gradually. And we've spent more time thinking, does it work? How do you titrate it? And we haven't had enough people on it that long to say, what's the best way to stop it?
Right.
So we're trying to figure this out as we go along. And it was started, of course, with high throughput screening, where they looked at different drugs, and this popped up as one that could work. And if you think that's bizarre, why would it be that? And then you looked at the history of it, and it was really an antimicrobial drug.
Right.
You look at the history, it was part of the rubber manufacturing industry.
Yeah.
Then I need to turn on my hook up my battery here.
Oh, sure. Go ahead.
Okay.
Yeah.
Hold on.
Sure.
Just let me hook it up here.
So I'll just take over for a second while you do that. We know that it is also a vermicide, but you know, the fact that it is not been proven as a very effective vermicide, it is a broad spectrum treatment, like you've mentioned, SIRS and MERS. Thank you. You know, it can be effective with a lot of these different things, including this study that was done on HIV. So we think it might be effective on viruses. So it definitely is antimicrobial and have some effect on a lot of the different things that Lyme patients may struggle with. So that's why I think people can get such a big herx, is because it's really, really effective. It may not be for everybody, but it is, when you take a look from the outside, it looks like a Lyme patient's dream drug, really, because
Right.
of that.
Well, it's, if you look, they originally were testing it as an anti-parasite drug. And then part of the logic was that if you're testing a drug, you take some yourself to see if it's safe. They took some, it was okay. And then they went out and they celebrated. And then they had a couple drinks. And then they both got sick. And they realized, well, gee, we both did. Maybe that has something to do with medication. So then it was mostly then focused as a psych drug. And even though there are a few articles with malaria and now cancer, which, interesting, you know, one of the cancers that we associate with Lyme disease, so a brain tumor. And, but it goes, there's always been a confusion of what's a psych drug and what's a antibiotic. Our first antidepressant was a tuberculosis drug. And many of the things considered for COVID, one is fluvoxamine, which is a drug we use for obsessive compulsive disorder.
Wow.
And even Haldol and Haloperidol and a couple of the tricyclics appear to have some anti-microbial effect with COVID. So it's not always a clear demarcation of what's a psych med. And is that because they just also have the property, or does that show that a lot of psychiatric illness has an infectious disease origin?
I believe it does, but I'm no doctor.
It makes sense.
Yeah, well, it does. My first Lyme doctor, Dr. Ronald Wilson, I dearly love that man. He says, taught me from day one, if it quacks like a duck, probably is a duck. So nonetheless, I take that into moving forward, treating my kids. We're still all treating until there's a known cure. I'll never let off the gas pedal with my kids or myself, because that's when I know Lyme will find its way back in from some sort of stress, as we all have stress in life. So before we move on, I did want to ask, what is your recommended maintenance dose, and how long do you see? I know I tend to gravitate toward Dr. Liebner's information and Dr. Kinderlair. I didn't realize you had that much time under your belt using Disulfiram for Lyme. I would have been interviewing much earlier if I'd have known that. But, you know, 60 to 90 days on the core dose, maintenance dose, target dose, whatever you want to call it. What do you see as far as symptom reduction or getting rid of symptoms altogether? What's your core dose, and how long?
Well, I've had people that were acutely suicidal who aren't now, and now are working from having been on it. And some people, I end up at a pretty low dose, 50 milligrams every other day sometimes. And it's hard to get some people up higher.
Yeah.
And maybe you need to combine it with something that maybe is better at treating the Bartonella or some other co-infections. So in the end, I think there may be a combination.
Yeah.
A part of the dosing was based on what's the concentration needed to kill. But the concentration needed to kill in a test tube may be different than the concentration needed to kill in the body. And it does seem like it penetrates somewhat better in the cells. It's hard to explain, you know, what works in a test tube and what works in the body can be different. So that was the thinking of the original dosing. And I think we have to figure this out as we go along. Now, if you look at how do we decide clinical treatments? Now, what's viewed by some as what they call the gold standard is controlled clinical trials. But that shows some other population. It doesn't show you.
Right.
And I think we have to look more at clinical experience, clinical wisdom. What you really need to do is like do surveys of doctors who are on the front line treating a condition, and they say what works, what doesn't work. And then you can learn from that, because those are the people that are trying this and trying that.
Yeah.
Particularly when you want a fast answer to something and you don't have the time to do these trials that can take an extended period of time. And even these trials, they're not the magic that some people play them up to be. They are useful and they have a value, but you have to look at all pieces of evidence. You can't only look at double-blind controlled trials. Some things you just can't do that way. And that's the issue, like, for instance, with the Tuskegee trial, where that went on too long, looking at what's a natural course of syphilis. And there's a point where when you know something is reasonably effective, you really can't do a controlled trial anymore because there's an ethical issue. So you can only get halfway there when you think there's enough evidence that it works, but then it's, now if you know something works, how can you put someone in a control group? Now, if you look, for example, the Klempner trial, if you remember that.
Yep.
In the Klempner trial, they said, well, it shows that antibiotics for these chronic people don't work. But you had to read the fine print of that article. In the fine print, what they said was that people that were PCR positive were excluded. And why did they exclude PCR positive people? Because it would be considered unethical. So the people that truly had Lyme, who had proof of Lyme in their body, were excluded from that trial. And the people, therefore, the group you wanted to study, that would have been the group.
Yeah.
However, because of ethics, you couldn't give a placebo to that group. So therefore, you really couldn't do that study.
Effectively.
Because you were only giving it on people that were found to probably not have Lyme disease, to have the antibody reaction, but have no PCR evidence of the presence of the organism. So it was a selection bias of the people that would probably not respond to antibiotic treatment. And then that's used as proof that further antibiotic treatment would work, and it was really a flawed study design.
Right.
So you, and you could say, well, that's a double-blind controlled trial. Yeah, it was, but look at the design of it. When it's designed in a way, it was designed to fail.
Yeah.
And a lot of these studies that are these considered that way, you have to look at the fine print, you have to look at the detail, and you have to look at all the pieces of evidence from every direction.
Yeah, that's really interesting. I don't want to point the elephant out in the room right now, but there's one going on right now that is such high doses of disulfiram. I'm questioning the design there, and I really think, like you mentioned, the ideal perspective should be coming from the clinical knowledge that the physicians are seeing of watching people get better, symptom reduction, psychiatric symptoms being reduced by what treatment and for how long. I think that's ideal.
Well, problem is, once you lock into a protocol, you're stuck. You can't tweak it as you go along. That's the problem. And it's also, if you have a design, and this is happening with a lot of clinical trials, is you have clinical trials and all of a sudden COVID comes along.
Yeah.
And if you're doing a clinical trial on disulfiram in an area that's highly epidemic for disulfiram, not highly epidemic for COVID, how is that going to impact things? Now, in some ways, maybe it's a study of disulfiram for COVID, all right? And it maybe could be, can you change the study design after you've started it? And look at, well, how do these two things interact? But the way it is, it's rather rigid with these NIH trials where it's hard to do that. You're stuck in a study design. Now you can do a post hoc analysis after the fact, but you're stuck in your original study design by the nature of how these things are done. You could do a pilot project that looks at things in another way, and that might be more useful than the more formal study that in a large number of studies are basically ruined because of COVID. And that's ruined a lot of the variables of ongoing studies in many places for many diseases right now.
I don't want to forget to ask, you had mentioned Bartonella. That is such a really big topic in our, I didn't mention earlier, but I started the Disulfiram experience for Lyme support group, and I was the first moderator on the bigger group, the anti-abuse Disulfiram for Lyme support group. But we're watching about 20,000 patients. Not all of them obviously are taking Disulfiram for Lyme, but there's a lot of conversation, a lot of useful information that I've been we've been watching go by, and a lot of the concern is how to treat Bartonella with Disulfiram. What are you seeing having the best result? As you know, psychiatric stuff is really a big issue for Lyme disease patients who also have Bartonella, rage, etc. What are you seeing having the best result clinically in your practice for Bartonella along with Disulfiram?
Well, it's when you get Lyme, a lot of times Lyme it's a misnomer. It's not just Borrelia burgdorferi.
Right.
It's probably a co-infection. A lot of the people that maybe just have Lyme and nothing else, maybe they don't do that bad. And but the people that we see invariably have Lyme, Babesia, Bartonella, maybe Ehrlichia, and probably Epstein-Barr, other co-infections. So there's an interactive co-infection. Now, Dr. Breischwert and Greenberg did a study of a patient who had Bartonella, and they really were quite thorough. And they didn't find anything but Bartonella. They couldn't find Lyme, they couldn't find Babesia, and it was a child that took a catastrophic nosedive, and a straight-A child, and then they were basically agitated, psychotic, and then they treated it and turned it around. So you can start a lot of people. Now, this isn't really my area, treating with the antibiotics. I'm more looking at the psych piece of it. So usually I'm working with someone who's treating the antibiotic part of it, and I'm doing the psych part. And certainly you see rifampin. Some people start with doxycycline, and then other strategies for the Bartonella. And we could question whether the Disulfiram helps it some, but it probably not so much.
Right, that's what we're thinking.
And there's probably a little more evidence for the Lyme and probably the Babesia, but Bartonella less so. So it may be that you need a cocktail, similar to what you see with AIDS, where there's this cocktail approach, and that you need this cocktail, something that would treat the Bartonella. And it's hard because some people have it in their system, and having it positive and having it cause the symptoms is another story. So you look at what are the symptoms that make you think Bartonella more. Now you can see the psych symptoms. You see the tenderness in the soles. You see the Bartonella stria. You might see the skin findings. The where there's the
rash, you mean?
Like blood vessels. Yeah, no, it's
over Bartonella, stretch marks.
Yeah, but not the stretch marks are unique with Bartonella, but there's other rashes too.
Right.
Like an angioma is what I was trying to think of.
Oh, okay.
But the stretch marks, they look like a boat with a wake sometimes, and they're in different locations, and they're not the same as, let's say, from pregnancy or rapid weight gain.
Right.
And but pain on the bottom of the feet, and more of the chills, the sweats, and you do see a lot of the mood lability with it. So it's hard because so many of these symptoms overlap.
Right.
What are the symptoms that are more diagnostic that make you think, aha, this is Lyme or Babesia or Bartonella? There are not that many symptoms, but there are a few symptoms that you look at that maybe set it apart as saying what's the main culprit. So having the presence of the reactivity in the blood test in your body and having the manifestation of the disease can be two different things. You can't always say there's a cause-effect relationship, but the more it's a pattern, it's pattern recognition. It's the pattern that goes with Bartonella. It's a pattern that goes with Babesia. with, let's say, the sweats, the drenching sweats, and the air hunger,
Yeah.
and the muscle aches. So there's a few things like that, or with Ehrlichia, where there's boom, a rapid onset of symptoms, and whereas Lyme sneaks up on people more gradual. Those are the things we look at to try to differentiate. But when you have a complex interactive infection, the way I'd think of it is I'd compare it to a fox hunt. If you went out in the woods with a rifle, you probably wouldn't be very effective. But if you have people, horses, and dogs, the interaction of those three species has more of an effect than either one or two alone. Now think of that with an infection. When you have a complex interactive infection, how do they interact? And in this case, you're the fox, okay? So you have this interaction that's not really understood. It's not 1 + 1 + 1. It's a multiplying interaction. And a lot of times you see someone gets Epstein-Barr and they have a pre-existing case of Lyme, and then all of a sudden Lyme gets worse, or the other way around. How is it that they interacted and then the disease took off and it exploded? We don't really have a good handle on that, but that's something we need to look at, better understand.
Yeah. Very interesting. Okay, so what would your ideal treatment look like using Disulfiram to treat the psychiatric effects of Lyme disease? You said you would titrate up, stay on it for a duration, and titrate down, but how would a patient know, or a physician know, in the reduction of symptoms, or how would they know to titrate down?
All right, I think what you're looking at, and I think this is true with any treatment, I think the lowest I have is 5 milligrams, and I have one person at 750.
Wow.
And that's a large male.
I was going to say, yeah, it has to be a guy, big.
And now, I think what you look at is a point of diminishing return.
Okay.
Now, here's a puzzling thing with Lyme disease. Okay, so let's say somebody gets Lyme disease, and are there current symptoms a result of current infection and immune provocation from the presence of the organism in the body, or are there symptoms from prior injury that's already done and over and done with? So you could think of a hit and run infection where it did its damage and it's done. And treating it further doesn't have any further benefit. So is that the case? How many of the symptoms are from prior neurological injury that's done and you can't undo?
Yeah.
And like treating Alzheimer's, you may be able to do something, you're trying to prevent further disease progression, but the injury that's already there is there, you can't undo it. So you're looking at, if you reach a point of diminishing returns and you're not seeing further improvement, and that goes on, and one logic can be you go and this is an antibiotic logic, go 1 month without a Herxheimer reaction. And not everybody gets a Herxheimer reaction. But if you go a period of time that you're at a plateau and there's no improvement, no Herxheimer reaction, then it might be that you've accomplished as much as you're going to accomplish. And it's at that point that you would back off, whether it be Disulfiram or some other treatment. And I think it's the same logic. And it does seem like Disulfiram is probably the most optimistic thing we've had for quite a while. It seems better than vancomycin and doxycycline and ceftriaxone by the research that was done.
Right.
So why not use it? And if there's something better, that would be fine, or a combination with something that would be good. Yeah. And that's something that we need to look at. So, and maybe it would be a study to do a survey of clinicians who are on the front line. What works, what doesn't work. Although people that are in academia kind of mindset, that it's seen as, well, that's not a valid study. You should only do the controlled trial. There's a rigidity that nothing else is considered valid scientific.
It can be allowed and
evidence.
Yeah.
And I'm not saying that I think that's useful in some cases, but you can't be so rigid that that's the only evidence you look at. You have to look at every piece of evidence from every angle, not just look at it in one specific way.
Yeah. Yeah, that's really useful information, just to help other people have an open mind who are researchers and so forth. The one thing that I wanted to ask, I think is really important, you've touched a little bit on this, but to caregivers, psychiatrists, etc., what would you recommend as tests for them if they see that what symptoms might they look for leading to infection being manifesting as psychiatric symptoms?
Well, it might be the majority of psychiatric symptoms are related to infections in some way.
I think so.
Although it may be old symptoms, and it's, if you look at it historically, the old theory was demon possession. So therefore the treatment was torture, and that would drive out the demons. And then we blamed everything on the mother, okay? And that was, schizophrenia, whatever. It was we blamed the mother, but that didn't really hold up. And really it was the opposite, because when you have a child who's impaired, the mother would hoover because they know that child isn't independent and they need more attention. So it's that we did a great disservice by hanging on to those theories. And there is some psychodynamic things that causes mental illness, particularly trauma and lack of nurturance, developmental impairments. That makes sense, but and then there's genes, but you can't put it all on genes, because you can have identical twins and one has an illness and the other one doesn't. One's schizophrenic and one isn't. One's autistic and one's not, and they're identical twins. And although there is a genetic susceptibility, but what is the environmental trigger? Now, if you look at environmental triggers, a lot of times it's infections, allergies, toxins, deficiencies. You work your way down list. And then when you look at when someone goes from health to illness or back to health, there's an altered gene expression. Certain genes go on and off. For instance, when we treat depression or other illnesses. And a lot of the genes that get turned on and turned off are immune system genes, more so than neurotransmitter genes. So a lot of times when we look at the brain, there's two parallel communication networks. One is the neurotransmitter system and the other the immune transmitters. Okay. Now in psychiatry, we pay attention to neurotransmitters and ignore the immune transmitters. In immunology or rheumatology, they ignore the neurotransmitters and just pay attention to the immune transmitters. But you have to pay attention to both, because they're both parallel communication net systems within the brain. And so a lot of times immune disorders are a key thing in causing mental illness, knowing that infections are probably the leading cause of altering normal immune functioning, which thereby alters stress reactivity and susceptibility to depression, anxiety, etc. Because if you think evolution is really a very perfect thing, and if evolution is so perfect, why is there all this mental illness? It makes no sense unless our regulatory systems are damaged by something. Mm-hmm. So there's something in our environment making us maladaptive, whereas by heredity, we were born with more adaptive capabilities that somehow are being injured. So I think an awful lot, you have to think of it that way, but it's a different language, because immunologists or infectious disease doctors don't talk much to psychiatrists and vice versa. They're like living on two different planets. So you have to look, and the link is immunology, psychoimmunology. That's the link that pulls it together. So you have to cross disciplines, and people that would otherwise not work together have to work together to really understand this. You can't just use silo mentality and stay within your soul field and ignore all the other things from all the other fields of science. You have to go beyond that and cooperate with people that speak a different language than you.
Yeah, that's really an intelligent way to look at it. And very appreciative from the Lyme community, because coming from where I came from, starting at 8 years old, treatment is compartmentalized, and you know, just because my arm aches doesn't mean it's not an overall infection. So I really appreciate that. Is there anything that you want to add to being able to bridge these gaps within treatment that you're seeing as one of the leaders in psychiatry, as far as how we can bridge the gaps to bring infectious disease doctors, psychiatrists, rheumatologists, how can we bring them together?
Well, I think that probably the bridge is immunology, is the immune system. And for psychiatrists to recognize that the immune system has a lot to do with mental impairments, and for people in general medicine to recognize that immune disorders can impair mental functioning, that's probably the bridge that would connect those two, you know, different ways of thinking.
Yeah.
If everyone could understand that better, and we think that's the field of psychoimmunology. We have these psychoimmunology meetings in the castle in Germany every 2 years, and we talk about these issues. Although this past year we couldn't have it because of the pandemic, so we did it, you know, on the internet, and that's what we've been doing with it recently. And I think eventually that will catch on. I think eventually people coming out of training, I've heard a concept that when a scientific advance occurs, it may take 50 years for it to filter down to the general population. And now that we have the internet, I think it does happen quicker.
Yeah.
But it takes a long way for people. People are trained to think in a certain way, and it's hard for them to shift. I was trained as a psychoanalyst, and that was my training and that's the cause of mental illness, to think that way. And I shifted, and we all have to shift and be open to new ideas. And that's would help us move forward, that and cooperative effort, and not get in the power struggles of who's in control, the psychiatrists or the infectious disease doctors, and do it in a cooperative way, not in a competitive way.
Yeah. Well, I've asked all the questions that I had as important today. I so appreciate what you do. Please keep doing what you do, because it's so important. So many of these infections do lead to stinking thinking and psychiatric disorders that affect generations. So we really appreciate all that you do. I do have these t-shirts. This is, I always tease.
Oh, great.
This is my uniform for doing
wonderful.
So we have one of these we're going to be sending you as a gift today to help.
Oh, great. All right. I'll wear it on the beach in New Jersey. Okay.
Very good. Yeah.
Okay.
So thanks so much for all that you do and doing this interview and spending time with me today to help Lyme disease patients understand how they can take Disulfiram safer, and getting information out to other medical experts in the success that you're seeing using Disulfiram. I know some people have given up on it and moved to other drugs because of the side effects, but I think sometimes these are dosing issues and genetic issues. It doesn't mean it's going to work for everybody.
Right.
But I think the slow approach, I think you're the only one I've interviewed or talked to that has gone as low as 5 milligrams, and I think that's real smart, because then you can kind of see what's going to happen, where you're not getting the cytokine storm starting from going too high, being a maverick, so to speak, and then having to address with steroids and so forth that can have an impact on the overall immune system. This seems like a much better approach.
Yeah, I think with dosing in general, like with psychotropics, I can see 100-fold, sometimes a broader difference of the lowest dose versus the highest dose. One drug, anafranil, clomipramine, which I use for obsessive compulsive disorder. I have one patient who's on 2 milligrams, and that's a dose that works. I've had another patient on 600. Now, the maximum FDA dose, I think, was around 150 or so. It's been around for a long time, but there's always someone who's a rapid metabolizer and a very slow metabolizer. Lyme patients in general tend to be on the slow side. They mostly need the lower doses, maybe tied in with the low body temperature that some have, but there may be other factors there. And then often when they recover, they then maybe tolerate higher doses. But a lot of times you make a mistake by starting with the smallest starting dose, and it's too large. And so a lot of times you're either using compounding pharmacies, or you're chopping up pills or opening up capsules, and better you give too little and do it slowly than too much and have to pull back. And there's no rush with this. I think this is a chronic illness, so it's not like you have to do a quick loading dose.
Mm-hmm.
Better you do it slow and low and gradual.
And what is your ideal dose for a 150-pound person? I get this all the time because I've made notes of what Dr. Kinderler typically sees more sensitive patients versus what Dr. Liebner has the most experience. He may have 375 for a 150-pound person as a maintenance dose. And I know this is individualized, and this isn't for somebody to at home listening to this to go take this dose. But what do you typically see? Dr. Kinderler typically would have somebody at 250 as a maintenance dose for a 150-pound person. Is your dosing that you see on a commonality basis much lower than both of those, yeah. Or is that?
I don't know that I want to go by pound so much as the individual response.
Okay.
But for that, maybe 250, sometimes 375.
Yeah.
But it's an individualized thing. I don't think I would want to go to 500. I've been using Disulfiram for decades.
Yeah.
For patients with alcoholism. And every now and then I would give it to an alcoholic, and we would start at usually 500 milligrams the first day.
Yeah.
And I would give that, and then they would say they had all these different symptoms that weren't in the package insert, and it made no sense. And so then I started people at 250, and even still some people would have these, and I couldn't understand why they had all these side effects. And then, it never dawned on me that this was probably a Lyme patient that wasn't recognized a Lyme patient.
Yeah.
And you're giving 500 milligrams to a Lyme patient. Think of the Herxheimer reaction that was probably causing.
I did. I got up to 500.
We were clueless at the time.
Horrible.
Yeah.
Bad idea.
But that was a lot of times the way people were dosed, starting at, now, more often, even 250, so rather than starting at 500. But they were done, people were started both ways. It's probably maybe that's a very rapid diagnostic test, who has Lyme and who doesn't. But I'm not recommending it as a diagnostic test, though.
Yeah, no, I don't hear that. Okay, and then one of the other things, I just lost my thought that I had, treating with Disulfiram, would you call it a game changer?
Yes, I think it is. I think it is a game changer, right? I think it is probably the most effective treatment that we have for Lyme, but you have to use it in a way that's most effective.
Yeah, and now we're getting some time under us.
Yes.
You guys all coming together and talking about it, and you are speaking on the ILADS conversational board, correct? And you're all communicating within ILADS of who's doing what, correct?
Yes, and there's other boards we do that we kind of share different ideas of what works for this or what works with COVID and what doesn't, and the latest thing, and it's sometimes changing. What combination? And probably it's a combination approach that's going to end up working. But it always has to be individualized. Mm-hmm. There's nothing that works for everyone. And there's one rule of the thumb is there's always some treatment that works for someone, and there's always someone who can't tolerate a treatment. So it always has to be individualized. You can never do a one-size-fit-all with anything.
Do you have any experience? I know before our interview you said you don't have a lot to offer as far as supplements, but do you have any recommendations that you have seen be successful in Lyme patients as far as something that they can do on their own to help improve cognition, brain fog, Anything that helps Lyme patients with brain function that you've seen that's not
Well,
SRI or,
yeah, more restorative sleep. That helps the brain fog because anything that gets them in a less inflammatory state. I think the brain fog goes more with more inflammation. So looking at your diet, your lifestyle, what pushes you toward weight loss, what pushes you towards being more pro-inflammatory, chronic stress. And it's just a lot of times it's the common sense things that we're told that we don't always follow.
Yeah, I wanted to just touch on that before we go. I was told before I was diagnosed with Lyme that everything was stress related. So to me, I'm hearing psychosomatic kind of stuff that Lyme patients are always told, well, this is in your head or this is stress related. And I got so tired of hearing that because, yeah, I was a college student who worked 2 jobs, but that doesn't mean that I wasn't meditating daily or doing yoga or practicing, healthy coping mechanisms or treatments. So, people have busy lives, but that doesn't mean that their busy lives are stressful to them. But I just wanted to mention that stress is definitely a big contributor to inflammation, but it's not always the cause.
Right, well, stress will bring out whatever you're prone to, but that would not be a cause in and of itself. And a lot of times when doctors don't understand the etiology of something, they'll call it psychosomatic or psychogenic. I did an article on that about of psychosomatic, somatopsychic, multisystem illness, and medical uncertainty. And you have to differentiate those. And a lot of times you're looking at multisystem illness that causes both general medical problems and psychiatric problems, like we see with Lyme. But it also can be somatopsychic, where an illness of the body has emotional distress. So if you have fatigue, you will be distressed. And that's somatopsychic, not psychosomatic. There is really no such thing as some psychosomatic fatigue, right? And psychosomatic illnesses are lifelong. So that but they're not purely psychosomatic. Usually there's a psychosomatic component. Let's look at GI problems. If someone has irritable bowel and they avoid lactose and gluten, then they may be less symptomatic. And if they're under less stress, they can afford to be more careless with their diet when they're under higher stress. But they have that pre-existing susceptibility that stress brings out. And even though there may be a psychosomatic component, and the body, when you're under state of alarm, it shifts your body's resources towards emergency functioning. So you're more in that hyperadrenaline state. And you can do that for brief periods, but usually then if you're in that state chronically, then that has some physiological consequences. But an awful lot of doctors and people don't understand the brain-body connection. And there is this mistake of using medically unexplained symptoms, bodily distress disorder. When you're sloppy and don't do an adequate exam, then something is categorized as psychosomatic, psychogenic, medically unexplained, when it's not. It's really just a result of inadequate examination and inadequately conceptualization of what's the etiology of a person's conditions.
Yeah, it would be really great at the front line in the physician's office across the board if we could have a better guideline for them to follow to pick up on some of these really obvious. I mean, I had all the hallmark symptoms going to GI doctors, for instance, severe pain, etc., and fatigue. And I had a friend laugh when she asked, well, what's the symptoms of Lyme disease? And I told her, and she was like, I do that all the time. It's totally different. I didn't want to impress. But, these are severe fatigue. This is, memory loss in a severe way. This isn't like, oh, I walk into the room and I forget what I'm getting. This happens all the time where I would have to, when I was really treating, I'd have to use my iPhone to follow directions to talk to me where I knew I was going where I was going, but along the way I would forget. I mean, it's just completely crazy how severe sometimes this stuff. Way better now, but it would be really great to see something like that happen, to pick up on a lot more infectious reasons why people are having these types of symptoms, to link it all together and treat it effectively.
Just like we were talking before about a bridge between infectious disease and psychiatry, we have to look at a bridge between general medicine and psychiatry, looking at linking how there is that interplay between the two.
Yeah.
And how, what psychosomatic medicine kind of falls between the gaps. It's not in the DSM-5, really. There are a couple conditions there, but it's not, we don't really delve into what is psychosomatic in the DSM-5 and in general medicine. So it's like a stepchild of psychiatry and medicine. It's lost in the gap a little bit, and we need to do a better job connecting. But that's the way it is, where we get compartmentalized in medicine, and we can call it silo mentality.
I can't tell you how many times I've heard, I don't know how to help you, or you're the healthiest sick person I know, or you're the sickest, healthy person I know. Because, if you don't know what tests to run, somebody like myself walks into the office and, my blood pressure's, super low in the dirt, and, my heart rate is low, and, I look flushed and I'm barely functioning. But everything on paper they're looking at, they're like, oh, well, we see this a lot of times with athletes. Well, I wasn't able to do a pull-up to save my life, but if they knew
the best answer there is, this is outside my area of expertise, and I don't know. And I recognize that you have some kind of symptom that, based on the way I do an assessment, I can't understand it or find it. So somebody has to look in some other way to understand what's going on. I think that's the best answer, but sometimes it's hard for someone to have humility. Humility is a very good trait in medicine. Yeah. Arrogance is a very dangerous trait. And so when we don't know, and there's an awful lot that we don't know. There's known knowns and known unknowns, but the problem is unknown unknowns, that which you don't know that you don't know. And that's the problem. How do you deal with unknowns unknowns? Yeah. Do you deal with that with humility, or do you deal with that with arrogance?
Yeah, to a patient, that's an unacceptable response, going to a physician to have them throw up their arms and say, I don't know what to do with you. To a patient who's been to 20, 30 doctors, that, you hear that left and right. It would make better sense to bridge these gaps within medicine across the spectrum, to say, well, I don't know what to do with you, but this guy might, and keep people moving in a direction versus, throwing up the hands, and Lyme patients go to bed and sometimes don't make it out. I'm not going back to bed. It's one thing I always think every single day. I'm so grateful to get out of bed. I'm not going back until 10 p.m. I'm done for the day. But that's a big thing in medicine. I think if a patient could say anything, it would be that. Please don't throw up your hands to anybody and say, I can't help you. Always give somebody hope that somebody will be able to help them, and try this guy or woman and see what happens. But I certainly appreciate everything that people and physicians have done to help me and my family. And that's why I do this, is because I want to pay it forward to help the next family save money and time and get better faster. That would be excellent. So I'm super happy to hear that Disulfiram is working for you for over 2 years now.
All right. Well, Lyme disease is a emerging, poorly understood condition, and the understanding of it is emerging slowly over time. So it wasn't taught to us in medical school. It may be good to teach in medical school. How do you deal with an emerging disease that's not understood up to now? How do you approach that? And there's a lot of things, like, for instance, the COVID. No one was taught how to deal with this a year ago. Right. But yet, if you're taught how to approach with something that's emerging and unknown, then you have that formula that you can apply whether it's some new thing a year or 2 or 5 years from now that doesn't exist today. So you know how to attack it and have an approach, and you're not spinning in circles forever. And you have an organized approach. It happened with AIDS. Different things that have come and gone like this. We see it with infectious disease, but it isn't always an infectious disease. It might be something else.
Yeah, yeah. Do you have a website that you can tell patients and any of the medical community that would like to learn more, where all of your research and publications are in one spot?
No, it's not all in one spot. I do have a website, but I don't think I've revised it for 20 years. So mentalhealthandillness.com. And I do, for instance, right now I'm posting things on Lyme and COVID-19.
Yeah, I'm in that group. It's great.
Right.
Yeah.
And then I'm giving a talk coming up for London for the Nutritional Academy of Nutrition. And that's going to be on YouTube, but probably the best way is a Google search, or look on PubMed, or look up some of the articles I've done.
Great. Well, my website is texaslymealliance.net and disulfiramforlyme.com. For anybody else watching, I'll have this video on YouTube and share it on my websites as well. And I just thank you so much, Dr. Bransfield, for meeting with us today. Really appreciate what you're doing. Keep it up.
Thank you, Christine. It's been a pleasure. And
yes,
good luck.
Sir.
Okay.
Thank you. You too.
Thanks. Okay. Bye.
Bye.